Good evening and welcome wherever you are across Australia and New Zealand and other places around the world tonight. We've got a few attendees. My name is Brett Ayres, and on behalf of the Canon Medical team, it's great to have you along for this webinar. And tonight the webinar is going to be on the art of breast ultrasound, and we're very excited to have Cindy Rapp as our presenter tonight. And for educational events, you go to our website, which is anz.medical.canon, and if you click on the education there, you can sign up to receive notifications of any events, and you can look to see what events we've got going on. In the year on October 26th will be the Sydney Anatomy Day, and this year it's going to be Stephen Bird and Andrew Grant presenting at the University of Sydney in Camperdown, and the subject this year is going to be on nerves again, so unveiling the wonders of ultrasound nerve imaging. So tickets will be on sale soon, and we'll send out communications when they are. Webinar, it's with Cindy Rapp. Cindy is based on the west coast of the USA. She actually works for Canon Medical Systems USA, and she's a senior manager of National Strategic Business and Luminary Development. And most importantly is that she's a sonographer, and she's an excellent ultrasound educator. She's also a fellow of the American Institute of Ultrasound and Medicine, and also a fellow of the Society of Diagnostic Medical Sonography. And she's no stranger to our shores. She's been to ASA conferences before, ASUM conferences before. The first time I ever saw Cindy was at the Melbourne one of ASA in 2004, where she did a presentation, and she's terrific. And tonight she's going to be presenting on the art of breast ultrasound. So without further ado, Cindy, are you there?
I am here, bright and early in my time zone.
I know, I wasn't sure whether to say good evening or very good morning, because it's very, very early. I think you're up before the birds.
Yeah, it's definitely before the birds.
Definitely before the birds. Okay. Before I hand over to you, I was just going to mention to everybody that if you've got questions to ask, we'll answer the questions after Cindy's presentation. And but you can type them in the question box, which you'll find on some screens. It'll be, I think, the top left-hand corner, top right-hand corner of the screen, and some screens it'll be at the bottom. But do enter questions, and at the end of Cindy's presentation, we'll endeavour to answer as many as we can before the end of the webinar time. So Cindy, I'll hand over the presentation to you.
Okay, great. I'll stop showing my early morning face and we'll get going.
Okay, and we'll see you on the other side.
Thank you. Okay, are you able to see my slides okay?
Absolutely, thank you.
Perfect, thank you. Then we'll go ahead and get started. So calling this the art of breast ultrasound. And just for those of you that aren't real familiar with Canon ultrasound, I'm going to give you a brief introduction to the I-series. As a disclosure, I am an employee of Canon Medical in the US. And the main system, probably our #1 system that we sell over here in the US, is the I-series. The Prism Edition was our latest release on this, a very powerful platform that we have with that. What's new with the Prism Edition? It's a whole new beamformer. So we've gone from CPU technology to graphic processing. I always say thank you to the gaming industry for taking ultrasound where it's at today. You know, all new circuitry, the beamformer. This will allow processing up to 4 times faster moving into the Prism Edition compared to the previous edition. And I think what really makes the imaging superb is the transducer technology, our dynamic microslice technology. And so kind of comparing your standard, what we call 1D array transducer. On most machines, it's a one-dimensional. So if you look at the short axis, or what's called the elevation plane focus, there's a fixed focal point that you have no control over. So what you'll notice on some of the other machines, if you're scanning something very superficial, things may be fuzzy, You have your sweet spot, and on high frequency linears, that's about 1.5 centimeters in depth. As you go deeper in the image, you'll see that things also get a little bit fuzzier. With the I series, we have our dynamic microslice technology. So we're using matrix array. We have the ability with each element of the transducer, we can control how we send that signal in. So we can delay it, that we can get very thin beam profile from the near field to the far field. So if you're looking at skin surface or even deep against the pectoralis muscle, you're going to see things a lot sharper. Much thinner beam slice. We know the thinner the slice, the better the resolution. And then looking at this image, now one thing I probably would have done would be gone into a trapezoid, opened up the image a little bit wider. But just to show you the penetration, this is 6 centimeters in depth, utilizing an 18 megahertz linear array transducer. So a high-grade carcinoma, you can see it's multifocal. There's a small lesion just right up here, kind of at the 10 o'clock position. But penetration is something very important to us in breast ultrasound. And rarely do you have to go that deep in imaging for breast at 6 centimeters. 2 transducers that we utilize quite often here in the States, even a lot of places can use just the 18s, an 18 to 5 megahertz. If you do shear wave for breast, you can do shear wave on this transducer. I know some of our competitors have to drop down to a 12 megahertz for shear wave. But what we want to do is increase the conspicuity, be able to see subtle lesions against the background tissue so that things will pop out at you, having really good contrast and detail resolution, maintaining clinical markers. So if you have little calcifications or something, being able to see the shadowing behind lesions, all of these are very important for ultrasound. Now, with our new Prism Edition, we've added a feature that is called iBeam Plus. And what's nice, it's something that you can either turn on or turn off. So if you decide you don't like it, it's a one-button click to turn it off. And I think as imaging has progressed over the years, it's almost gone to more of a smooth, smeary type of an image. And so with iBeam Plus, we go in and kind of remove that smeariness and give you much better contrast and detail resolution. When you first look at it, you might think it's a little bit too contrasty. But really, when you start comparing the two, you'll notice much better detail. And I am fighting a cold, so if you hear a little break in there, it's just because I had to give a little bit of a cough. Looking right here at this, can you see my arrow that I'm pointing with on the screen? Is that showing up for you guys?
Yes, we can, yeah.
Perfect. So this is a TDLU, a terminal ductal lobular unit. You can see the extralobular terminal duct right next to it. And really just looking at the detail, this is kind of what we call a foam cyst, or kind of a fat fluid level. Look at how much better the resolution is with the iBeam Plus. Now I know this is not a breast image, but this is a thyroid, but it's going to kind of show you the progression that we have with the Prism Edition. So in standard imaging, you can see this large thyroid nodule, great visualization of the muscle. Once I go into iBeam Plus, you're going to have an increase in your penetration. Look at how much better you're seeing the muscle in the far field. Now, once you are in iBeam Plus, you have the ability to go to a full focus mode. So instead of having focal zones, you can actually have the system do all the focusing for you. So once again, we give you that ability to choose that option. It's not something that you're stuck with. We also utilize a 24 megahertz transducer quite a bit for breast imaging. And I'll tell you, when Canon first came out with this transducer, I was like, okay, great, what are we going to do? Scan like the first centimeter? But really excellent penetration resolution with a 24 megahertz. And now with the iBeam Plus, we have even better penetration for that. So sometimes scanning structure is very superficial. It is hard to see structures close because you get a lot of reverberation. On this particular image on the left, when we scanned it with a competitor's machine, they thought it was solid because it filled in with reverberation. And actually notice there's not enhancement, there's posterior shadowing. That's just an area of fat necrosis. Looking at a clip, you can see how well we see that. Also, just the kind of detail and contrast resolution that you get with that 24 megahertz. Our eyes have been trained a lot to look at the hypoechoic portion of lesions. but really look at the echogenic halo that is spreading around here. So this is all spread of disease and just unbelievable contrast and detail resolution. Another thing is using our microvascular imaging, so picking up vessels in their structure. So a lot of times we see debris index, or it could be a papilloma. Looking at SMI, you can see there is flow. So we know that's definitely a solid nodule. And also looking at SMI, even on a structure where the vessels are at 90 degrees. Typically in color, you're not going to get much of a Doppler shift, but with a microvascular flow, you'll see that even at 90-degree vessels. So just to show you some image quality on the I-series, this is scanning clustered microcyst with the 18, comparing that to the 24. Just look at the skin line, how much better you can see that. The pre-mammary fat, much better detail, much better enhancement, and just internal detail. But notice that at about 3 centimeters, we start to lose penetration. Now, this image was taken before the I-beam plus, before the Prism edition. So now with Prism, we can get about 4 centimeters of penetration. And just showing you a difference between 18 and 24 megahertz on a small breast carcinoma. Once again, look at that echogenic halo that surrounds the lesion. Here's another image with the 24 megahertz. Not only do you see the hypoechoic mass, look at the infiltration of the cancer also in the surrounding tissue. And then this is with the 18, long extension of the duct almost right up into the nipple. Also look at the echogenic halo that surrounds that lesion. And this is just looking at a lumpectomy scar, but I love it in that I can see from skin line all the way down right into the lumpectomy site. Once again, this is utilizing the 24 megahertz. And once again, maintaining your clinical markers, having that posterior shadowing, being able to penetrate to the pectoralis muscle is very important. So why do we utilize Canon Breast Ultrasound? The I-beam former, that dynamic microslice technology, having that very thin beam profile, and then having the ability of either an 18 or a 24 megahertz for breast imaging. So now we'll get started more in the clinical portion of it with the Art of Breast Ultrasound. I was kind of looking for an image that would go along with this, and that's why I love Google for. And this is actually one of the largest atlases of normal breast cells from MD Anderson. So I thought that was pretty cool for breast ultrasound. So our general goal for breast ultrasound, we are trying to make a more specific diagnosis than what's made with the clinical and mammographic findings alone. But more specific goals, we want to prevent unnecessary biopsies. If we can show that what the patient's feeling is just a rigid normal tissue or simple cyst, hopefully we can avoid having a biopsy. To prevent follow-up for mammograms, it's amazing how many patients are afraid of the amount of radiation that they're going to get from a mammogram. They don't have to have additional views, and ultrasound can answer it. That's great. Little do they know that if you get on a plane and fly across, the states or the country, you probably got as much radiation as you would from a mammogram. To guide interventional procedures, we all know that if you can see something under ultrasound, it's much easier to biopsy it with ultrasound than it is with stereotactic and other methods, and then improve the clinical and mammographic interpretive skills. So I'll show you an example of something that was given a BI-RADS-4 on the mammogram. We scanned on ultrasound, we can convert that to a BI-RADS-2. And then the last thing I put, find malignancies missed by the clinical and or mammographic exam. And probably in Australia and New Zealand, you guys are doing whole breast ultrasound. Maybe you're still doing targeted, but most of the breast sites that I go to now are doing pretty much whole breast ultrasound because of the dense breast law that they give or the patients have. So we know that patients may have what's called the normal mammogram, very dense breast, and with ultrasound, we can find cancers that didn't show up mammographically. So taking a look at indications. So I worked with Dr. Tom Stavros for 15 years in Denver, and we did quite a bit of research, wrote a book on breast ultrasound, but we took a look back in this is probably in the 1990s, why people were coming in for ultrasound. And you can see palpable mammographic follow-up. the one we all hate, pain. Pain is an indication, secretions and non-targeted. So back in the 90s, pretty much everything was a targeted breast ultrasound. We didn't do whole breast ultrasound. We took a look at this again today. I think that whole breast, that non-targeted would be a much larger section. But also going back to pain, with it being an indication, women, if they have pain in their breast, what do they think they have? They think they have breast cancer. So it's kind of a time for us to help educate them, letting them know that rarely is breast cancer going to be tender. Ask them if, they drink a lot of coffee, they notice it at certain times of the month, but kind of a way that we can help educate them with their breast ultrasound. So proper equipment, once again, requires excellent near field resolution, good spatial resolution, which is your axial and lateral, and also good contrast resolution. So talking about the lateral resolution, this is what helps minimize your volume averaging. And if we look at a transducer, 2 planes of the transducer that we deal with, the long axis, and then we already talked about the short axis or elevation plane focus. So things on the long axis that we can control are your focal zones. Moving those up and down will help give you better image quality. The elevation plane is where we don't have any control over. So looking at this image, I intentionally put my focal zone way down low. And in scanning, you could just see there's kind of something fuzzy, but notice once I move my focal zone back up, you can see that there's 3 simple cysts. Now, this was done with a 1D array transducer, so not a matrix array transducer. We already talked about that 1D versus a matrix array, how you're going to get that very thin beam profile utilizing matrix array. So looking at a very superficial structure, if you're utilizing a 1D array, typically you're going to need to do something to get that closer to what's called the elevation plane focus, about 1.5 centimeters. So with that, we would use a stand-up pad. So this, I'd have to call it, not certain exactly, is it solid, is it cystic, is it, what's going on, but getting it closer to that elevation plane focus. What I have here are 2 simple cysts. And you're like, wait, Cindy, that looks like it's a lobulated mass. How can you say 2 simple cysts? On ultrasound, we see structures best that are parallel to the transducer face. So a lot of times, the walls between cysts running right up at a 0-degree angle, that's your best angle for Doppler, it's your worst angle for imaging. So if you angle your transducer over and come in from the side, sometimes you can see that wall that separates these things that look like they're lobulated when they're really just structures adjacent to each other. Then looking at scan planes, cancer likes to take the path of least resistance. So as it starts to spread, a lot of times it will travel through that ductal system. Pretty much everything in the body that we scan on ultrasound is done in a standard longitudinal and transverse scan plane. So you can see if I scan long and trans, I might make this lesion look fairly well circumscribed. But by scanning radial, which are like spokes on the bicycle, and anti-radial, which is going to be 90 degrees, whatever your radial plane is, hopefully you'll pick up these subtle projections that go back towards the nipple or branch out away from the nipple. But it would be wonderful if our ductal system ran like spokes on a bicycle, but we all know it really doesn't. And a lot of cancers, if they arise out more peripherally, we don't know how that ductal system is running at that point. So the most important thing is once you find a solid nodule, don't just stick to like spokes on the bicycle. What I like to do is park the end of my transducer that's away from the nipple, hold it in that position, and then just sweep across the breast and find the largest dimension. Whatever the largest dimension is of the lesion, that's what I call my radial scan plane. Anti-radial is just going to be rotating 90 degrees to whatever the radial scan plane is. We're looking at normal anatomy, what we should expect to see. The skin, echogenic, probably about 2 to 3 millimeters thick. We then have a layer of subcutaneous fat. We have a pre-mammary fascial layer that comes along, and everywhere there's a Cooper's ligament, it goes up, attaches to the skin, and comes back down. That's important for looking at the spread of breast cancer because cancer likes to kind of invade up those Cooper's ligaments. Then we have the mammary zone. This is pretty much where everything happens. Most things occur in the TDLUs. This is where cancer arises, cysts arise. This is where a lot of stuff is happening. These little structures that you can see here are called terminal ductal lobular units. In a lot of patients, that's just at about 1.5 centimeters in depth. We have a retromammary fascial plane that we really don't see very well sonographically, the retromammary fat, and then the pectoralis muscle. So when you first start imaging, make sure that you can see all the way back to the pectoralis muscle. And so just here's comparison, looking at skin, a little bit of premammary fat. You can see Cooper's ligament, looking at the mammary zone down to pectoralis muscle. And looking at this type of image, I used to review images for ACR accreditation, and I would get some people that would call this ductal ectasia. And when you actually see this little white dot right here, that's the normal duct. What we're seeing is the loose stromal tissue that actually surrounds the duct. This is what allows ducts to expand and contract during lactation. And it's something that you'll see typically in younger women. If you have, I should say, women in probably their late 20s, mid 30s, young women have more gray glandular tissue, so you won't see it. And then as patients age, they get more fibrotic, and so you don't see that loose stromal tissue. So that's not ductal ectasia, that's just normal tissue that we see surrounding the ducts. And here's showing you long axis and short axis views of a little bit of ductal ectasia and a little bit more of ductal ectasia. So what's a normal measurement for fluid in the duct? There really isn't one. If the patient's asymptomatic, we don't get worried about it. So 50% of women over the age of 50, if you scan retrorenal, you'll probably see some ductal ectasia. It's very common for callbacks on mammograms is because of fluid in the duct. So we don't really get too concerned about that. So taking a look at variations, and it can be due to age changes, but also just people's body habits. We start out with just a little bit of premammary fat. You've got the mammary zone, pectoralis muscle. Notice I really don't see any retromammary fat. Then as things start to change, you get a little bit more retromammary fat. Notice how there's more premammary. You can see these Cooper's ligaments extending up more. Now the mammary zone is even getting shrunken a little bit, even more retromammary fat. And that we have just a little bit of fibroglandular tissue into completely fatty involuted breast. So just showing you the different types of breast tissue that will run across. These are patients that ultrasound's very good at finding cancers that might miss on mammography, whereas mammography is most sensitive in patients that have completely fatty involuted breast. So looking at the main ductal system and talking a little bit more about TDLUs, those terminal ductal lobular units. So the duct right near, close to the nipple, is called the lactiferous sinus. And then as it comes down, you can have these terminal lobules that are on the end or the anterior or posterior lobules. So these are just normal structures. Why it's important for us to kind of know the normal anatomy is a lot of times we can see that. This is a 19-year-old patient. Notice how she doesn't really have echogenic fibroglandular tissue. This is gray tissue, which is all glandular. This is the type of tissue you'll see typically in young girls or people who are pregnant and lactating. But notice this anterior lobule. Here's some terminal lobules and a posterior lobule. So the anterior have a very long extralobular terminal duct, whereas the posterior lobules have very short extralobular terminal ducts. And so here's just kind of looking at a pathology and a zoomed up image of what a normal TDLU looks like. But why is it important to know what TDLs look like? Because they can change within the breast. You can have normal TDLUs, they can become atrophic, they can become fibrotic. And then sometimes patients will have adenosis, which is like conglomerate adenosis, where the TDLUs get very large, which would make it very difficult for us to find a mass. So here's just looking at some ducts, and you can see here's the branching ducts. You can see a lot of fibrosis within this one. Notice how with these TDLUs, we're starting to get some adenosis. So if I had a small mass, it would be difficult to see that. And then when you get into conglomerate adenosis, you can see how it's very difficult. They're very dense breast mammographically and also more difficult to see things sonographically. So knowing what can happen to the normal structures like the TDLU is very important. So looking at mammographic sonographic correlation. I tell you, mammographers, they're great at understanding mammography and figuring out how to locate lesions. Sometimes it's something in sonography that we struggle with a little bit more, but here's just some of these diagrams that can help you figure out if it's in the upper or lower quadrant, inner or outer quadrant, and then figuring out the o'clocks. So here's just sort of diagrams showing you the right versus the left, and then dividing it and looking at the depth. So figuring out if it's in the anterior, mid, or posterior section of the breast. So these can be helpful for us trying to figure out mammographic sonographic correlation in finding those lesions. And now your CC projection of your mammogram, and this is kind of one thing I liked about having films, is I would take it and kind of hold it up and I'd go, okay, that's in the medial aspect. So your CC projection is telling you medial versus lateral. Your MLO is telling you if it's in the upper or the lower portion of the breast. But where it gets a little bit more difficult is as the breast is being compressed, and then we don't know the degree of obliquity that the beam came in when the mammogram was taken, it can cause lesions to project higher or lower than they really are on that MLO view. So when you're looking at correlations, your lateral lesions will appear to be located more superiorly than they really are on the MLO. And the more peripheral they are, the higher they're going to project. So a lot of times you'll think a lesion is going to be clear up at 10 o'clock and you're going to find it clear down at maybe 8 or 7 o'clock. And you're like, how could that be? But it's just the way things are. And just the opposite for medial. A medial lesion will appear to be located more inferiorly than they really are in the MLO. Same thing, the more peripheral they are, the lower they will project. So if you're like me, I'm like, okay, how am I going to remember if I need to go higher, if I need to look lower? Remember, muffins rise. So if you're looking at something medially, you're going to be needing to go higher than you think. Lead sinks. So if you're looking for a lateral lesion, go lower than you think it's going to be. And hopefully that'll help in correlating mammographic sonographic correlation. Now looking at the density on a mammogram, there's 3 densities we deal with. There is fat, which is anything that's gray here, calcium, and you can just see the benign calcifications. The third density is called a water density. So a water density is anything white mammographically. And here's a great example of where ultrasound can be helpful. But what's everything that represents a water density? Obviously, cysts are water density, but normal fibrous tissue and normal glandular tissue are also water density. Any solid nodule, does not matter if it's benign or malignant, is a water density, and then so is muscle and skin. So being able to correlate and figure things out mammographic, sonographically, remember everything that can represent water densities mammographically. So here's a patient that came in with a palpable lump on the left side, looking at this breast, pretty much a fatty involuted breast. So is ultrasound going to add a lot of information? Not really. So expect to see something like this. You have the skin, you have that pre-mammary fascial layer, you can see a Cooper's ligament. The entire mammary zone is filled with fat down to the pectoralis muscle. That's what a fatty breast would look like. Another patient, very dense breast, palpable lump left side. Looking on ultrasound, you're like, wait, Cindy, that looks like fat that you just showed me. But this is glandular tissue. So these are either very young patients, like the 19-year-old I showed you that TDLUs, or anybody who's pregnant or lactating. So you can see how mammography, you might miss something, and if you have an isoechoic lesion, it might be difficult to see that. Also on ultrasound. Another very dense mammogram. One of our radiologists I worked with, Steve Parker, he said, these are height-of-truck breasts. He said, you could put a semi-truck in there and not find it. But this is where ultrasound is very helpful. When you have these very dense fibrous tissue breasts, things are going to jump right out at us with that echogenic fibrous background. So that's where we're going to be more useful on ultrasound. Now, 4 things that you want to compare looking at mammograms to the ultrasound. Figure out the size. Look at the shape. If there's a point on one side, you should see the point on the other. Figure out where the location is, and your doctors may do cheat sheets for you. I'm sure your radiologists never get lefts and right mixed up or 10 and 2 o'clock mixed up. That was just, our doctors. And then the last thing is look at the tissue density that's surrounding. If the lesion's surrounded by fat on the mammogram, then what you should see on ultrasound should also be surrounded by fat. So number one, figuring out the size. I know I'm going in and looking for a 2 centimeter lesion, and all I can find is a 1 centimeter cyst. If that cyst is surrounded by fibroglandular tissue, that's all water density. That's why my size doesn't match up. So I would just measure my cyst and then just take one caliper across that included the fibroglandular tissue. But take into account everything that's a water density, and that's very helpful for matching up the size. The other thing, how do we measure? Do you measure just the fluid, or do you include the echogenic capsule? The one thing you want to make sure is everybody in your department measures the same. We do include the capsule on all measurements because it is a water density. But if somebody measured a probable fibroadenoma inside to inside, patient came back 6 months later, they measured outside to outside, it makes something look like it's growing when it's not. So just make sure everybody measures the same. And the other thing, take into account everything that's a water density. This is a question I'd get asked quite a bit when I would do this lecture at different conferences. And, they'd never ask during the meeting, they'd come up afterwards and they'd say, I had this mass. I could see it on the mammogram, but I go in and I can't find anything on ultrasound. What's going on? Take into account everything that's a water density. Now, this really should not have made it to ultrasound. They should have done a spot compression mammogram before they sent it to ultrasound. But we know things sometimes fall through the cracks. And normal fibroglandular tissue can create a water density mammographically. Notice on the left, here's this ridge of fibroglandular tissue, same ridge of fibroglandular tissue. So if we're calling something normal tissue, a lot of times we'll do split screen images, mirror images showing the same location, right versus left. And this patient did go back for spot compression to make sure that it did compress out. But looking at the shape of a lesion, you'll see a 90-degree rotational difference when you compare mammograms to ultrasound. Think about how mammograms are done. It's pulled away from the chest wall, compressed down, so that you'll see lesions look like they're perpendicular on mammograms, and then on ultrasound, they're going to be parallel. Here's an intramammary lymph node. You can see perpendicular to the chest. On ultrasound, it is parallel. The other thing, lesions will always be closer to the chest wall when we take a look at ultrasound. Pulled away, so you're going to see more retromammary fat, and the lesions will look like they're a couple centimeters off of the fat. But on ultrasound, being compressed down, they'll be right against there. So here you can see this lesion pretty much, pulled away from that pectoralis muscle. On ultrasound, it's actually indenting into the muscle. So location, they will be closer to the chest on ultrasound. And here's a coned-in view of the CC projection. This is kind of what is called the forbidden zone, this area that comes up here. So this should just continue on. So this little area peeking up was concerning on the mammogram. This was given a BI-RADS 4. Actually, it was given a BI-RADS 0 because it was recommended for ultrasound. But going in on ultrasound, we were able to scan real time and see that there was some ductal ectasia that came along and continued down. It's always hard to show a single image. It shows you what you're scanning real time. But notice that there's fat anterior. Here's this ridge of fibroglandular, same ridge of fibroglandular. Size, shape, location surrounding tissue match up. What was worrisome mammographically with a BI-RADS 4 can be converted to a BI-RADS 2 with ultrasound. So basically the patient did not need any further workup. And this is the one I think all sonographers hate. You get this one patient whose films were like on 14:17 films. You see this one little mammographic ditzel do, and you go and you start scanning. And you're in the room what seems like forever, and you can't find anything. If you can't find anything, a lot of times these are little isoechoic lymph nodes. And if we think back to Anatomy 101, what are the three structures that course through the body together? Your lymphatics, your nerves, and your blood vessels. Like notice there's this vessel here. So what I've learned is if I turn on color Doppler, kind of have my transducer transverse, scanning in and follow the blood vessel that's feeding, a lot of times that'll lead you right to where those little intramammary lymph nodes are. But if you can't find it, assume it's solid, recommend a short interval, one view mammogram follow-up, not another ultrasound, since we weren't able to find it the first time. But they can be very tough to find because a lot of times they are isoechoic. So looking at diagnosis, patients that came in, number one thing we would find would be normal fibroglandular tissue, simple cyst, complex, intercystic, fibroadenomas, cancers. You can see about 5.6% lymph nodes and ductal ectasia. Kind of the rundown of what we were diagnosing in our department with breast ultrasound. So optimizing your system, very important. And one thing that you want to do is make sure that when you're talking about something being echogenic or hypoechoic or isoechoic, that we're all referencing the same thing. So the one thing that we want to compare everything in the breast to is fat. Fat is on that 50-yard line. It is what you want to have comparison. So if I say a lesion is isoechoic, it's the same echogenicity of fat. If I say it's hypoechoic, it's darker than fat. If it's echogenic, it's brighter than fat. So make sure that when you're setting up your machine, you have fat set so that it is medium gray. If you're only going to listen to one thing that I say, this is the most important, always make sure fat is medium gray. So here we've got, look at that, nice cyst, great through transmission, but one problem, what color is my fat? It's black. So I actually need to turn my gain back up so that fat is medium gray. When I do that, this is not a cyst. This is a high-grade invasive carcinoma. Now, we always think that shadowing is worrisome for breast cancer, but basically a third of cancer shadow, a third of cancer has normal sound transmission, and a third of cancer enhances as much as a cyst. So this had obvious malignant features within there, but look at the enhanced through transmission. And I can remember doing breast ultrasound, oh boy, way back, you know, when I first started in the 80s, and one of the doctors said, oh yeah, if it enhances, it's a cyst, and if it shadows, it's cancer. I mean, that was kind of the knowledge way back then, but high-grade breast cancer will give you enhanced through transmission. So always make sure your fat is set at medium gray. We'll talk a little bit about palpable nodules, and so I don't offend anybody. Several years ago, I went back to school to get my bachelor's degree and took a fine arts class. This is a Rembrandt painting, and the story behind it kind of fits with what we deal with ultrasound. He had just given her this pearl necklace, so to take and show her appreciation, she put his hand on her chest. And how many times do you get a patient that comes in for something palpable? You get the patient on the table and you say, where's your palpable lump? And they're like, I don't know, my doctor found it. So remember, our number one goal, prevent unnecessary biopsies. So if we can show that what the patient's feeling is a simple cyst, a fibrous pseudomas, complex, complicated cyst, depending upon, you know, how aggressive you are, fibroadenomas, that we can help prevent unnecessary biopsies in looking at that. If the indication is a palpable lump, before you put your transducer down, feel the lump. It's going to tell you a lot about it. If it feels like it's a BB, you know it's going to be very superficial. The other thing is, while you're scanning, run your finger under the transducer, make sure that what you're feeling and what you're seeing are the same thing. And I'll show you why in a second. The most common palpable lump is a ridge of normal fibroglandular tissue. And I'll tell you, if a patient comes in for their ultrasound, you know, we thought pain, they thought it was cancer. Well, if they feel something in their breast, in their mind, they definitely think they have cancer. So I'm not sure if you're allowed to talk to your patients or if your physicians talk to them, but it's nice that they let them know that what they're feeling is normal tissue. Make sure that they check that area once a month. And I always tell them the day you start your period, check and make sure it's not changing, because you don't want anything to progress into something else if you're going to call it normal fibroglandular tissue. But most common thing that we see is just normal fibroglandular tissue as a palpable lump. Now, looking at cyst, the tension cysts, the ones that are round, are the ones that patients come in with that are palpable. These I call lazy cysts. I mean, next time you have one, they can be huge. You know, rarely do you feel those. In fact, this is basically called nature's implants. You know, if you aspirate that, you know, that's going to completely change. But what you might feel is that fibroglandular tissue coming up and over there. But really, Those lazy cysts aren't palpable. The ones patients will feel are the round ones that are kind of under pressure. So sonographer came in, she was great. She did it palpable. She felt and make sure that, this is what the patient's feeling. She put the transducer down. Boom, there's a cyst. But looking at it, it's really not a tension cyst. So a radiologist went back in and rescanned. And this is what the patient was feeling is the isoechoic fibroadenoma. So your eyes are going to be drawn towards the cyst because there's more contrast between there. But if she would have run her finger underneath that, she clearly would have seen the fibroadenoma adjacent to the cyst that is what was palpable. So some of those cases where you have those isoechoic lesions, make sure that that is exactly what they are feeling. Now, using standoff pads, if you have 1D array transducers and things are very superficial, a lot of times we need to use a standoff pad. If you've been in ultrasound for a few years, you might remember we had standoff pads that are about 3.5 centimeters thick. If you find one of those, don't use it, or your beam will be focused right in the middle of that. So ones that you need to use are probably about 1 centimeter in thickness. But what I don't like about standoff pads, number one, I'm doing something palpable. If I put the standoff, I can't palpate the lesion anymore. I don't know about you, but I always get an air bubble right where I need to look. And the other thing is I'll be scanning and I'm like, what am I looking at? And I look over at the patient and I'm now doing her thyroid because it slid all the way up to her neck. So instead of using a standoff pad, use a big glop of gel. And if you've got some breast departments have that really nice lotion gel, you really need kind of the Aquasonics. The gel that you can use that will kind of glob up. Then when you put your transducer down, it all smushes away. So what do? You add more gel. But little trick, you take your little finger, put it underneath the edge of the transducer. When you put the transducer down, you now have a built-in standoff pad. That's called the Rapp technique. So here's an image from a few years ago, a couple things that are wrong. Number one, here was a palpable area. Focal zones are way down here. And this is a 1 centimeter marker right at this area. So it's not within the elevation plane focus. So once we move the focal zones back up, get it closer to the elevation plane focus with gel, we actually have a suspicious lesion that you really couldn't see there before. So always remember that elevation plane focusing in your imaging. Split screen imaging, we'll look at that for asymmetric tissue density. And so what you want to do is not 2 o'clock on the right and 2 o'clock on the left, but you would do 10 and 2 comparing it mirror images. And you can see there's water density in the right axillary segment. We can see normal fat on the left. One nice image shows you we've got accessory breast tissue here and normal fat on that side. So if we're looking at normal tissue, a lot of times we'll do that split screen imaging just to show that. But variable compression with 2D imaging. And this is really where I say breast ultrasound is truly an art. And I'm a general sonographer. I did gallbladders. We did all kinds of stuff. I'll tell you, breast is one of the hardest things to do because you could be 1 centimeter away and not see it. You could use too much pressure. You could use not enough pressure. It truly is an art to be doing breast ultrasound. So if you use too light a pressure, you can create artifactual shadowing. And here's what looks like a probable BI-RADS 3 fibroadenoma, but they're shadowing. That was just scanning with too light a pressure. Now we had one of our accounts called us in and said, your ultrasound images are they're just not that great. I mean, I don't have any detail. I'm getting shadowing. I'm not seeing structures well. And this is the images that one of the sonographers was submitting into the account. When I went there, their lead sonographer says, oh, I rescanned that patient. Can you believe this is the exact same patient? It was a sonographer who had art and she knew how much pressure to use. So if you're using too light a pressure, creating artifactual shadowing, that you're not seeing things real well. So the only thing I probably would have given it one more click on depth so that I could see the pectoralis muscle. But look at how clearly you could see that fibroadenoma, how much better the structures are seen by adding the right amount of pressure. And here's another example. You know how we sometimes struggle to see enhanced through transmission or things up against, the pectoralis muscle? Scanning with light pressure, versus scanning with heavy pressure. Look at how much better I can see the borders. So it's really figuring out, if you're not seeing something great, try coming in from a little bit of a different angle, applying a little bit more pressure, but be an artist and create those absolute beautiful images. Now, we were in on this account, and the sonographer says, I just don't feel like I'm seeing this as well as I should. And I said, are you applying heavy pressure? And she goes, yes, I am. I said, try lightening up on your pressure a little bit. So here was a case where when she lightened up her pressure, it actually came in much better. So sometimes you need to use heavy pressure, sometimes you need to use lighter pressure, but figuring out the right amount of pressure is key for breast imaging. And I'd say probably about once a year, we would get something like this. A patient came in with a palpable lump, small cancer hiding in that fibroglandular tissue that wasn't seen. But a lot of times we become tunnel vision. We're trying to prove that, that's a simple cyst. There's nice smooth borders, anechoic, enhanced through transmission. We might take an image that looks like this. That was created by just scanning with too light a pressure. But the most important thing is when you compress down to try and remove artificial shadowing, make sure you don't slide off of a true lesion. So when I do compress down, I want to sweep back and forth to make sure that I didn't just slide off of that lesion. So one of these is a cancer and one is not. And I used to ask people to vote. I like that little poll that you were able to take on too. People want to see it on Facebook or whatever, but nobody would ever vote because everybody was afraid to. So the main point is I can take perfectly normal tissue and create what looks just like a breast cancer by just scanning with too light a pressure. But once again, when you compress down to see if it's artificial shadowing, make sure you sweep back and forth that you didn't just slide off of a lesion. So looking at variable compression with color Doppler. So this was one of the patients that we had in our breast ultrasound book that we wrote that came out in the early 90s. And for any of you who are doing ultrasound back in the 90s, a lot of work was being done with color Doppler, trying to prove, things being benign versus malignant, looking at the resistive index. And, as you're scanning, you notice your hands getting a little tired, and so started to press down a little bit more. And look at how I could change peak systolic velocity and change the RI with just using more pressure. I'd lighten pressure back up, flow would come in. I can compress down, flow would go away. Stavros came in, we're watching this happen. We thought, cool, we are onto something here. Here's a benign lesion. If we press, we can make the flow go away. We thought for sure we'd be able to use this to tell benign versus malignant. Next time we had a patient with cancer. Notice high-grade cancer, enhanced through transmission. Compressing, flow goes away. You say, well, what about power Doppler? More sensitive. Doesn't matter if it's color, power, SMI, anything. If you're using too much pressure, you will not see blood flow in the breast. So what I like to do is open up my box big enough to try and get a vessel somewhere adjacent. Also notice that these are lesions that we have the enhanced through transmission on. Your high-grade cancers are the ones that are going to light right up with color Doppler. So cystic lesions, we see clustered microcysts all the time, but if something's not a simple cyst, add color Doppler, use light pressure, open your box big enough just to make sure that it is a simple cyst, because some things that look cystic may not be. This was a medullary carcinoma. It only takes us a second to turn on that color Doppler, and if it is a high-grade lesion, you will pick up flow in that. So other pseudocystic lesions, lymphoma, metaplastic carcinomas, some of your high-grade invasive ductal carcinomas, and metastatic lesions. This almost looks like one of those little foam or gel cysts, but notice it's microlobulated. This was a metastatic intramammary lymph node. And here was a patient who was in her 67 years old, pretty much a fatty involuted breast, and all of a sudden, up on her mammogram popped up what looked like a cyst, very well circumscribed mammographically. It's not a simple cyst. So what do we need to do? Definitely turn on color Doppler. You can see all the flow in there. It goes for biopsy. This turned out to be metastasis from a uterine leiomyosarcoma she had no idea that she had. So if it's not a simple cyst, turn on color Doppler, use light pressure. The other thing we'll talk about is fremitus. This is another thing that we kind of stumbled upon. It's done in power Doppler. And if you look it up in the dictionary, it's a thrill felt by humming. So what you need the patient to do is hum, but it's got to be in a deep voice. If they have like a high-pitched voice, it doesn't work as well. And I'll tell you, fremitus worked better on older equipment than it does today. Fremitus is an artifact. Engineers try to eliminate artifacts. And so it's something that we'll use, but I'll be honest, it used to work a lot better in the older days. And here's actually the case that we stumbled upon. We found or figured this out. She was another one in our study that we were looking at that you could see a lesion mammographically. I go and scan, I found the breast cancer, Dr. Stavros comes in and he's checking the patient. And she started to get nervous because I had done all the imaging. He comes in, the images he put on power Doppler. And one thing he noticed is the cancer never filled in with power Doppler. The other thing he noticed, there was a lesion down here or an area down here that also did not fill in with a fremitus. So once you optimize your image, move your focal zones down, opened up that box, we figured out she had multifocal disease that we hadn't found at first, or I hadn't found, because it's what's called satisfaction of the search. You're going in looking for that one lesion, you found it. But literature reports multifocal disease can be as high as 60% of the time. So if we see something suspicious, we should look around just to make sure there's not multifocal disease. So where do we use fremitus? Sometimes if we're questioning if it's a fibroadenoma or a fat lobule, this is a fibroadenoma. Fat would have filled in with the fremitus. Multifocal disease. Hey, see, I was in Australia. That's when there were 12 apostles. Beautiful area that I was able to visit when I was there. Isoechoic lesions and artifactual shadowing. So multifocal disease. Sometimes you'll have patients that get diabetic mastopathy. Very dense mammograms, no matter how hard you push on ultrasound, you can't get rid of the shadowing. Doing fremitus because it comes from the chest wall up, it completely filled in. We felt comfortable in calling that just artifactual shadowing. But taking a look at this lesion here, which was palpable, this is what we call one of those barely visible lesions. And then in doing fremitus, you can see that there is multifocal disease. In fact, you can see it going right through the ductal system. So can be helpful in looking at that multifocal disease. But once you understand breast sonography, you'll love it. And that was not Photoshop, that was actually real. So with that, I will stop sharing my screen and hand it back over to Brett to answer any questions.
Thank you, Cindy. That was a terrific presentation. Okay, I think your camera's just come off.
Okay, you want my camera back on? There we
go. Yeah, we'll do the Q&A session together.
Perfect.
Yeah. Thank you for doing that. So we're at the section where people can submit questions. You'll find the question box probably on most people at the bottom of your screen to submit a question. Just for people that have joined us since the introduction, Canon Medical are a gold sponsor of ASA 2024 coming up in Sydney at the end of this month. We've got actually a handout which will be at the bottom of your screen. You can get a PDF of the things that we've got going on. If you're going to ASA 2024, you can book in for some time at our booth and our hospitality suite to do some scanning and talk to staff and see our latest machines. So please, by all means, do that. And also too, we've got a program of our sponsored lunch and learn activities and our Canon workshop sponsored workshops. Okay, we've got a question here. I'm just going to open it up and I'll just stop sharing there. Okay, our first question is from Andrew. Do you routinely use elastography? If so, do you always use shear and strain or just shear wave?
So a lot of the sites that I go to, and I would say majority do not use elastography. We do have some breast sites that do, and I would say right now most people are using shear wave. In the good old days, it was strain elastography. And where shear wave is probably the most helpful is in those when you're questioning, is this a BI-RADS 4A or could this be a BI-RADS 3? If you have an obvious BI-RADS 4 or 5, it's not as helpful, but in looking at some of those indeterminate lesions, that's where it could be helpful. Shear wave also is sensitive pressure, just like color Doppler. So if you are going to use shear wave, you need to kind of use a little bit lighter pressure for that. But I was just at the Cleveland Clinic this last week, and they use shear wave on every one of their solid nodules that comes into the department.
Terrific. Okay, thanks for that answer. Thank you, Andrew. Our next question is from Kieran, and it's how reliable is vocal fremitus for routine use in terms of specificity and sensitivity?
Yeah, fremitus is one of those things, we probably used it a lot before. It's not for sensitivity and specificity. I mean, we never did a paper saying how reliable it was. And I think with today's equipment, it's not as reliable as it used to be. But if you have a question, if something's really there, you can do it. But I think what sonographers always like or don't like is when a physician goes to a conference, they hear somebody talk on it, they now want you to do fremitus on every single patient, but it is not something you would use for every single patient, and few applications that it could be beneficial for.
Okay, thank you. And thanks, Kieran, for that question. Our next question's from Quinn. Is it possible to have a cancerous lesion if it's avascular?
Yes. In fact, your low-grade cancers, the ones that have intense shadowing, rarely are you going to see blood flow in those. And then your intermediate grade cancers, which are the ones with normal sound transmission, you may or may not see flow within them. But your low-grade cancers, you will not see blood flow within those.
Okay, thanks for that question, Quinn. And our next question is from Kylie. Thanks for your great presentation, Cindy. Do you have any tips to optimize viewing of calcification in ultrasound? Great question.
Very good. I didn't put all of the features that Canon has into my presentation, but we do have a feature that is called MicroPure, which will highlight calcifications, kind of gives it a twinkle. They have to be smaller than 700 microns. And typically they are ones, if you have calcifications inside the lining of the duct lining is echogenic, the calcifications are echogenic. MicroPure does not help on those. But if it has sort of a gray background, it will pick up those calcifications. But looking for the DCIS calcifications that are seen mammographically, those can be very difficult just with 2D imaging alone because they are echogenic and the duct lining is echogenic. Good question.
Okay, thank you. And thanks for that, Kylie. Okay, the next question is from Alan. Do you have any tips on lymph nodes? How you determine if a lymph node is probably inflammatory versus metastatic disease, etc.?
Yes, so people always they like to measure lymph nodes. You know, when I worked with Stat, it was more of an eyeball type thing. But when you use color Doppler or your SMI Doppler, if you have a single vessel feeding the hilum, that tends to go along with your inflammatory nodes. And if you get what's called transcapsular branches that come in from the outside that are feeding in, that tends to go along with malignant nodes. Once again, the most important thing is to do a biopsy. Ultrasound is not truly reliable, but anytime you're seeing vessels coming in from the outside into the capsule, that is more suspicious for malignant nodes.
Okay. Thanks for that question, Alan. Got another question about fremitus, but it's just a sort of a clarification question, and this is from Peter. Does fremitus work because malignant tissue is more rigid, in inverted commas?
So fremitus will work with any lesion. So it's not benign versus malignant. If you have a fibroadenoma, if you have a cyst, it's anything that occupies space. It will be what I call afremitus. So you'll get the soft tissue around it that fills in, but the lesion itself does not fill in with fremitus. So yeah, it's not like the desmoplastic reaction of a cancer or anything. It's just something that I don't know, but it's with any type of a lesion that you'll get that. And it takes some getting used to, also a little bit of pressure. having the patient hum once again in a low voice, having a fairly low PRF, and doing it with the power Doppler. But next time you have a patient, give it a try. Have them. You're almost going to have to hum with them because they don't want to hum. So just tell them, or you have them Peter Piper pick, something that gets the chest wall to vibrate is what you need to do.
And it has to be a low frequency
Very
hum.
low voice.
Very low. Okay.
If they're high, it's not going to work.
Okay. Okay. Thanks for that question, Peter. Our next question is from Twee. And apologies if I've got your pronunciation wrong there, Twee. Does using the Zoom box reduce the sensitivity of Doppler? So does using the Zoom box reduce the sensitivity of Doppler?
I don't believe the Zoom box will reduce the sensitivity of Doppler, no. You're larger the box, obviously you're going to slow down the frame rates. If you've got microvascular flow on your current product that you're using, that's going to be your best sensitivity. Pressure is probably the thing that you're going to be, anytime I'm looking for the presence of blood flow, I put extra gel and I lighten up my pressure that I'm just making contact with the skin. I think that's going to be the most sensitive area for you. Man, you guys have got great questions.
Yeah, they're keeping on coming. Yeah. Thank you, Twee, for that question. Another one on Fremitus. Explaining to patients how to explain Fremitus to patients and minimize artifacts created. Perhaps it's to do with moving around. And what is the suggested color scale for breast lesions?
Yeah, so for Fremitus, are we talking about the scale? Yeah, for Fremitus, I want about a PRF, and everybody's machine's a little different, but a fairly low PRF, about 1,000. Color scale, if you're doing microvascular flow, going to put that low, but with Fremitus, PRF of 1,000 or less, and play around with it. And to explain it to the patient, I would just tell them, I'm going to have you hum, and it's going to just show some color on my screen, or something.
With the PRF, can you convert that to centimeters a second?
I'd say just use it fairly low. I don't know what. Yeah.
5-10 centimeters.
Yeah, probably about that.
Low.
Probably about 5-10.
Yeah. Okay. And that question was from Laura. So thank you, Laura. Appreciate that. Okay, this is a sort of a question comment from Sally. Finding patients in breast screen setting are still having biopsies even with all the new techniques. Not sure if this will change. So we have breast screen programs in Australia. Yeah. So anyway, thank you for that.
Yeah, and I'll tell you that breast screening does open up a whole new can of worms, and that's where I think shear wave can be helpful, because they're finding these cysts that are non-simple, that they're not sure but something solid. And if you do shear wave and it's blue across the background and the lesion itself is blue, that's not suspicious. So hopefully something like that can helpfully bring those numbers back down.
Okay, and thanks for that question, Sally. Next question is from John. Do you include the echogenic halo in the measurement of a hypoechoic lesion?
Very good question. So our eyes have always been trained to look at the hypoechoic mass. The ACR guidelines, which are our governing body for the breast BIRADS, are changing to include measuring the echogenic halo. So pretty much what we do right now, measure the hypoechoic, but then take another measurement extending out, including the echogenic. That is the spread of disease. If you read articles, they're going to say ultrasound always underestimates the spread of disease compared to MRI. And that's one reason is we had not been measuring that echogenic halo. So new guidelines are going to require us to do that measurement.
Okay, thanks, John, for that question. Next question is from Gina. What happens if the patient has multiple scattered cysts on both sides? Do we need to put color Doppler on all of them? Good question.
Very good. So what I like to do is if I put the transducer down and just start seeing cysts everywhere, I want to scan through the entire body, or not entire body, entire breast, and make sure that I'm kind of ignoring cyst and look for anything solid. So a lot of times we get wrapped around all the cysts. Only on ones that are clustered or not simple, I'll throw color on it, you know, and pretty much in documenting them, I'm only going to show those that look like an acorn cyst or a foam cyst. Foam cysts are the ones that are completely filled in with echoes. Those are just kind of, you know, gel or, you know, thick secretions or something in there. But those are the ones I'll do color Doppler, ignore the simple ones, and I don't put color on simple cyst.
Okay, simple no color. Yep. Okay, thanks Gina for that question. I got a long question now coming up. This is from Sarah. You speak about using ultrasound to change mammo-diagnosed BI-RADS scores to reduce them to prevent unnecessary biopsy. However, in our rural area, in conjunction with local specialists, we tend to biopsy anything questionable. So the question is, should we be working harder? Our general opinion is biopsy is better than waiting.
Yeah, so the example, if we can take something that looked worrisome mammographically and show that it is like ductal ectasia or something that's definitely a BI-RADS 2, which is normal structures, they wouldn't need to have the biopsy. But I always say, always err on the side of caution. If you have a lesion that you're not sure if it's benign or malignant, they're going to do the biopsies on those. So a lot of times we do get a lot of, you know, false negative biopsies. So
Okay, thanks for that. Thanks Sarah for that question. Our next question, you've sparked quite a few questions with Fremitus, and we've got another one. If I find myself in a situation, this is from Rosie. If I find myself in a situation where I want to use Fremitus, could you give a brief description on how to do it? Should I use light pressure, select power, Doppler, ask patient to hum? So just what are the quick steps to go with Fremitus, just to
yep,
recap?
she's got it down. She's ready to roll. So yeah,
Okay.
use lighter pressure, turn on the power Doppler, and just say, I'm going to have you hum here in kind of a deep voice and just go, so she kind of knows what you want to do. And once again, some of those images I showed were from older equipment where it worked better, but give it a try and see, or even sometimes if people talk, you're going to get it to vibrate, and the tissue around will fill in with that power Doppler.
Terrific. Okay, thank you, and thanks Rosie for that question. Our next question is from Helena. Wonderful lecture, Cindy. Thanks, Helena. What is your experience with breast implants and malignant breast lesions? So breast implants and malignant breast lesions.
I have lectures on malignant breast lesions. Guess I'm gonna have to come back. I need to come there in person though.
I think so, yes. Yeah.
Yeah, I'll just tell my US group here, yeah, I got to come over there. I had a whole lecture on implants where we can definitely see intracapsular rupture. We can see the snowstorm, the extravasation of silicone with ultrasound. You know, there's ways of doing that. You know, I go through all the BI-RADS features of looking at malignant nodes and what's benign versus malignant and how you look for that. So it's hard to answer that question in a single, you know, that's another hour lecture to cover that just goes over all the BI-RADS features and everything. So.
Okay, thanks for that question, Helena. Our next question is from Selma. How can we differentiate between ductal carcinoma and papilloma?
And that could be difficult. Intraductal papillomas versus that. I mean, once again, your biopsy is going to be the best thing. So both can light up with color Doppler. Papillomas do need to come out anyway. And so it's not going to be really us differentiating. It's just going to be finding the lesion, getting the biopsy. That's the true one that's going to tell you exactly what you're dealing with. But I told you how everything started in the TDLUs. Papillomas start in the main ductal system. In fact, if you have what's called a peripheral papilloma, that's a papilloma that did start within a TDLU. So Peripheral papillomas don't mean that they occurred out far in the periphery. That means they arose from a terminal ductal lobular unit, and those are more worrisome for papillomas. But majority of papillomas form in the main duct.
Okay, thanks for that question, Selma. Appreciate that. Okay, our next question is from Carolyn. Have you ever found a suspicious lymph node if a breast looks normal?
Yeah, thank you, COVID.
Okay, right.
I don't know about you guys, but lymph nodes are definitely abnormal quite a bit now after all the vaccines and stuff that people have got. But yes, you can have inflammatory nodes. And that's one reason sometimes people feel lesions in the axilla that we start scanning ultrasound. So if you see abnormal lymph nodes in the axilla and they've not had a complete breast workup, they should have a breast workup. But you can have inflammatory nodes. There could be other things going on, lymphoma. I mean, there's all kinds of things that can cause lymph nodes to be abnormal and have a completely normal breast ultrasound.
Okay, thanks for that question, Carolyn. Our next question, I think it goes over two parts from Marie's. How do we efficiently assess for satellite lesions? And the second part was that Marie's she had a patient recently where a satellite lesion was missed.
Yeah, they could be difficult to find. Now, I know here in the US, we have an MRI on every corner, and that's something that I know that you guys don't have, but any woman who's been diagnosed with breast cancer pretty much gets an MRI, and that picks up the multifocal disease. But anytime you see something suspicious, you should definitely sweep through that entire breast looking for multifocal or multicentric type disease within that breast. But they can be hard to see sometimes, and that's why we do a lot of MRIs here.
Yes, the US does seem to have a slightly more MRs available than
Yeah, you guys are much better at MSK.
Yes, yep. Okay, thanks Maurice for that question. Got a question from Peter. Is it still true to imply that high diastolic flow is an indicator of malignancy, that's neovascularization versus capillary?
No, I think in breast, because it can change so much just by the amount of pressure that you're using, that we really don't look at the resistive indices for benign versus malignant. It's more like if there's flow in there, that right there is the indicator that it's going to be something worrisome. But once again, on all of this, your biopsy is the true way to figure out what we're dealing with.
Okay, thanks Peter for that question. Got sort of a technique, a machine technique question, which I'll get you to comment upon. This question is from Selma. What is the accurate color scale for a breast scan? So,
boy, everybody's machine is going to be different.
Yeah.
So that's, kind of a rule. What I used to do in the good old days is I would take my color gain and I'd turn it way up so it was speckly in the image, and then I would turn it back until you just had the right amount, and then your scale, keeping it fairly low, that you're picking up flow. But it's one of those things that everybody's system operates a little bit different. I know that we optimize our machines when they're being installed for customers, that all the color and everything is pretty much set up. But if you feel like you're not getting flow, turn your gain up a little bit or drop your scale down a little bit just to see, to make it a little bit more sensitive. And also frequency that you're using. Remember, the lower the Doppler frequency, the better your color sensitivity will be. So if you're using too high of a Doppler frequency, you might not see flow. So lower frequency for color.
Great, thank you. Thanks for that question, Selma. I've got a question from Alison, and I think it's going to be machine specific, but I'll just see if you can give an answer that can apply to any, in this case, it'll be Canon machine. Cindy, what settings for Appli-Pura and precision do you use for best optimization on the Canon for breast imaging?
See, I don't do applications,
Yeah,
but I could, I'm trying to think if we use a 2 and a 3.
it
I'd
depends
have
on the
to go,
machine too, won't it?
yeah, I'd
So
have to go back and
yeah,
look at some of the
yeah,
images,
yeah.
but
I suppose in general terms too, for noise reduction and compounding,
right.
um, yeah. Uh, what are you looking for in an image? How do you tune in? I suppose.
So,
Um,
yeah, the one thing I find, we go into an account where they have equipment that's end of life, and they want us to set the machine up to look just like their current product, not what we can do to look. So a lot of the older images were very gray or smeary. They want us to use higher dynamic ranges than we typically do. We typically run with about a 65 on our dynamic range. And it's either a 4.2 or 4.3. It depends upon if they like a smoother image or they want a crisper image. It's just difficult to say because of anything we image, I think breast has its own special recipe from one account to the next more than any of the other imaging modalities.
yep, so true. Thanks for that question, Alison. Okay, here's a question from Elizabeth. And I think we've all been in this situation. How are you optimizing seeing the posterior border to measure cancers that are shadowing to keep it consistent? Yeah,
That can definitely be very hard to do. Um, if you have a Canon system, an 18.2 frequency is what we recommend using for the imaging. If you drop down to I think it takes it down to an 18, it gets rid of some of that shadowing that you might be able to see that posterior border a little bit better. We keep the 18.2 because it maintains clinical markers. But if you take that down and it removes that, you might be able to see it. Sometimes shear wave, well, sometimes shear wave gives you even deeper, but seeing the posterior borders, a lot of times it's a guesstimation on where to measure when you have those intensely shadowing lesions.
yep. Thank you. Thanks for that question, Elizabeth. Got a question from a lot of questions tonight,
I
Cindy.
guess
So I
I'm
hope,
glad you made some up in case there weren't any.
yeah, no, they're all here ready to read. So, and thanks everyone for being so involved. That's fantastic. This next question is from Samantha. Is there any routine use of color Doppler to pick up twinkle artifact on microcalcifications, which would then lead to a patient having a mammogram?
Yeah, unfortunately, those calcifications are too small to give you the twinkle artifact, like what we use for gallstones and kidneys and stuff. So unfortunately, the twinkle doesn't work on those. Even on clips, sometimes it doesn't work very well because it's too small of a structure to give us that twinkle.
Okay, just whizzing down to our next one. Okay, here's one from Stephanie. Thanks for your question, Stephanie. Would it be correct to say that contrast mammography would eliminate full scans of breasts, meaning it is acceptable to only do targeted ultrasound scans?
We could hope so. I know it's something that's out there that a lot of people are really getting excited about.
Yeah,
And if indeed it does do that, then we could go back to a targeted and not. But once again, I think it's limited sites that have that capability. Um, is everybody going to get into it? Or they're going to be just dedicated breast sites, that will do that. But it would be nice. And it does appear to be, quite promising.
yeah. So do you see that at many places at all, or just
I'm running
intermittently?
into it in the larger places, but I'm not
Yes.
seeing it everywhere. Yeah.
Okay. Yeah. Okay. Thanks for that question, Stephanie. Next question, another question from Andrew. Thanks, Andrew. Any techniques for differentiating FCC with DCIS other than the presence of color?
Color, he hit it right there. I mean, the high nuclear grade DCIS and you know, FC, they can look just like, in fact, in my solid nodule talk, when I talk about cancer, I show an example of that. One of these are clustered microcysts, one is high nuclear grade DCIS, and color Doppler is your answer for that. He answered his own question.
Okay, thanks again, Andrew. Got a question from Pauline, and the question is that she sees many patients who have had surgery. Any tips on scanning scars?
Yeah, scars are tough. You know, you can get granulation, tissue that's healing that will give you flow. I think a lot of it is, once again, correlating mammographic, sonographic correlation, making sure that it's not changing mammographically. And then if you think something's changing, are you getting increased blood flow? Color Doppler can be helpful, but you know, sometimes scars can be very difficult to evaluate, but doing your serial comparisons with a mammogram also.
Do you do any turning of the patient or anything like that?
I mean, I always roll them up. When we position them, we're trying to get the breast tissue as thin as possible. So bringing the arm up over their head, rolling them up kind of semi-decubitus just to thin out the breast tissue as much as possible.
Great. Okay. No worries. Thank you very much, Pauline, for that question. Okay, next question is from Amanda. What's your technique for looking for malignancy deep or around the nipple? Often you'll get lots of shadowing and need to compress to see.
So there's, man, see, they're getting into my solid nodule talk. But there's what we call two-handed compression, where you can take your free hand and push up against the breast and use the transducer to kind of come in from the side, and you can kind of scan around that way. We do a rolled nipple technique that we actually take the patient's nipple and put it right on the finger and scan directly over that. And then another thing that's very helpful on the Canon, we've got lateral gain. And so you can actually, instead of just doing your TGCs coming across horizontal, we can do the vertical, that we can take that TGC brighter and allows us to see behind the nipple where we have that intense shadowing. So you can adjust those things on the Canon to see retroareolar better.
Terrific. Okay, thank you for that question, Amanda. Got another question from Selma. If you've got a ruptured implant with suspicious lesion, what is your way to scan?
So ruptured implant, I mean, anytime a patient with implants, I always try and remember that we're there to look at the breast tissue itself, you know, and not necessarily focus on the implant as much. And then just go through all your BI-RADS features of what you're going to be looking for that would be worrisome. And then making sure that it's not a silicone granuloma that you're looking at, which basically looks like a polar bear in a snowstorm. It's just this white, ill-defined area, but you should be able to see that even mammographically if there's extravasated silicone in there.
Okay, thank you for that question, Selma. Okay, I've got a question from John, which again, it's to do with implant. For an ultrasound guided aspiration of pericapsular implant fluid, checking for seroma versus lymphoma, is this related to the makeup of the implant?
It very well could be. People's bodies react differently to a foreign body within there. And so we have had some patients that their body wants to reject it. So it's everybody's a little bit different in looking at that, the way that they will accept the implants or not. So, man, you guys are tough questions.
I know. It's
my goodness.
Yeah, you've
and we were worried if we're going to get one or two questions.
No, not at all. In fact, we're just, having said that, we're just on time now. and a lot of great questions there from everyone. Sorry that we haven't been able to get through all of them, and a lot of kind messages from everyone saying what a great talk, and I think I know that we'd love to see you in Australia again at some stage, Cindy. But yeah, no, thank you so much for sharing your knowledge and wisdom on breast scanning with us today. So just sort of in wrapping up, I've got to, and again, I apologise because we had so many questions, but we really do appreciate that because it really does make the webinar super interesting. And thank you, Cindy, for going through the answers so rapid fire there. Look, I've just got a few thank yous to say before we finish up. From Canon Medical, I want to say thank you to Pat Milne, to Beth Knight, Dana Lee and the marketing team, also to Paul Cousins and our big boss Jason Cotter for everything in making this webinar a realization. I wanted to just give a shout out to our friends from Sonos for Sonos who did some advertising for us to get the word out. That's Chrissy Walker and Prue McClimont and the Sonos for Sonos team. We want to thank them. I just want to say a quick thank you to Julie Quinn and Jennifer Lau from earlier in the webinar. And I just want to thank everybody for being a part of this webinar. It's been fantastic, chock full of information. What is going to happen is you'll get a replay link so that you can watch the webinar again. Just remembering that for CPD, people have had to be on for 50 minutes or more, and I hope that everybody fits that qualification. But most of all, I want to thank Cindy Rapp. Thank you, Cindy, very much for this great webinar. We really appreciate you sharing your knowledge. Just for those that may not know, if they've come on since the beginning, is it's actually now it's got to be like 3:30 in the morning for you now.
3:32.
3:32. So either you're getting up or you're going back to bed. One of the two. Go back to bed. No, that's a good idea. So just winding up. Look, big thank you, Cindy. Appreciate you overcoming the hurdles of a very late night, and also to I know that you're fending off a bit of a cold there. We really do appreciate it. So on behalf of everybody at Canon Medical, thanks everyone, and we hope to see you at the next educational event. Thanks very much.
Thank you, everybody.